All right.
Thanks. I want to welcome everybody into today's virtual speaker session. We'll be getting started in just a minute. Go ahead and drop in the chat who you are and where you're from and your Penn State class year. It is good to see everybody joining us this afternoon. We'll be getting started in 1 minute. Where else would you rather be than a Zoom full of Penn Staters? I'm Paul Clifford, CEO of the Penn State Alumni Association, and I'd like to welcome everybody to today's virtual speaker session, which is being recorded. Live closed captions are available for this event, and you can access them by clicking the closed caption button at the bottom of your Zoom video window, and then clicking Show Subtitle. You may also customize your caption view by clicking the Stream to Text link that is posted in the chat. We hope you enjoyed today's discussion. We're also live streaming today's presentation on Facebook Live. This live stream has been made possible through our gracious support of a donor and the Fund for Access, Ideas, and Audacious Goals. Today's presentation will be archived and available on the website after the event. This afternoon, we welcome Dr. Ray Hohl, the director of the Penn State Cancer Institute in the Penn State College of Medicine at Hershey. He is a professor of medicine and pharmacology and holds the university professorship in medicine. Dr. Hohl is a medical oncologist, hematologist, and clinical pharmacologist, and has broad experience as a clinical and translational researcher. Each year, advances in cancer research bring life-saving benefits to bear against more and more types of cancer. This includes the practical aspects of managing cancer, including how to choose an oncology team, getting a second opinion, participating in clinical trials, and when and how palliative care fits in. Dr. Hohl will discuss efforts to improve cancer patient treatment outcomes by utilizing existing patient information to make therapies more effective and accelerate the new discovery of treatment approaches. He'll also discuss what breakthroughs and advances might lie ahead for the field of cancer by highlighting the challenges and opportunities at the cutting edge of immune oncology. Thank you for joining us, Dr. Hohl. I'm going to turn it over to you.
Thank you, Paul. It's really a pleasure to be here, and I welcome everybody who's taken the time this afternoon to join this session. So as Paul introduced me, I'm a medical oncologist and a researcher, and I see patients. I have a clinical practice that includes primarily patients with blood disorders and blood cancers, such as leukemias, and do bone marrow transplants, as well as some other innovative therapies we may talk about a little bit later, and also see patients with primary brain tumors. And I'm really very fortunate to be talking to you today as the director of the Penn State Cancer Institute. And what I was hoping to do today was really I have about 10 slides or so, and I was just going to run through a brief overview for you as to what the Penn State Cancer Institute is and what we're all about, give you a sense as to the general areas that we focus on, and then spend a majority of the time, hopefully, answering your questions. And I'd be happy I'm happy to talk about virtually anything, as Paul and I mentioned, or we're talking about a little bit earlier. So I'm going to go ahead and share my screen. Okay. Okay, we had this working moments ago.
Go ahead and give it a try now.
Let's see. This is interesting. It was there and it just lost. Do you see me at all?
I am seeing you. Right now, I am not seeing the presentation.
Okay, let's try this.
All right, now I am.
Oh, you do see
Well,
the
now I'm
presentation?
not.
How about there?
I do not.
Okay.
Not yet. Sorry.
Okay, no, that's okay. Okay, I am going to.
Okay, it appears that Carrie's possibly able to share it for you.
Okay, Carrie.
I see the presentation now.
Okay. Let's see here. Okay, so Carrie, you're driving?
Oh.
Okay, let's try this again. Let me share it.
Perfect. All right, I see the presentation now, and it appears that maybe Carrie is sharing it. So there we go.
You have it, Carrie?
Okay, and let's just use it in this mode, Carrie. And there we go. Perfect. All right, Dr. Hohl, we'll turn it over to you. I think Carrie's going to be driving.
Okay, very good. Thank you, Carrie. So the first, what you should see right now is the title slide. And so really, in football season almost, really talking about leveling the playing field for cancer care and treatment. If we go to the next slide, Carrie. So the mission of the Penn State Cancer Institute is listed here. And I just want to take a moment to really explain to you that we really span the entire continuum from the basic discovery of fundamental mechanisms that underlie cancers to developing new therapies and really getting the therapies out. And we really have a very grandiose but important mission statement that we're really influencing cancer care, education, innovation, and collaborative research. And our focus is on central Pennsylvania, but as you'll see, it's also beyond. On the right side of this slide, what you can see is, for those of you that are familiar with the University Park campus, and I suspect most of you are, is the Millennium Science Complex at the top. And on the bottom is the Penn State Cancer Institute, which is located in Penn State's College of Medicine here in Hershey. So we're about 100 miles separate from State College. But importantly, the Penn State Cancer Institute really has members that are on both campuses. And in fact, we have members that also include some of the other campuses of Penn State University as well. Next slide, Carrie. So for those of you that are looking back, and maybe some of you graduated with degrees from some of the colleges that are listed here, you can see that in addition to the College of Medicine, where we have 154 faculty members that are doing cancer-related research, we also have a number of individuals, close to 75, at the University Park campus. And you can get a sense as to the colleges that we draw our members from, and then the various departments. And really the largest college that we have most of our members, the largest group is really the College of Health and Human Development, as well as Agricultural Sciences. Next slide, please. The Cancer Institute is set up so that we have the senior leadership, which is myself, and members, as listed here, spread across what we refer to as 3 scientific programs. Each of these programs are really describe what it is they do. So mechanisms of carcinogenesis is really understanding the fundamental basis for why cancers develop, and discerning if there are new ways to treat these cancers. We have next generation therapies that are really focused on, are there new drugs, are there new approaches that we can use to treat patients with cancer. Then we also have cancer control, which is all about understanding why we have a very high cancer incidence in the Commonwealth, and how we can detect cancers earlier, and when somebody survives their cancer, in terms of survivorship, what can we do to prevent cancer from coming back and improve their lifestyle. In each of these 3 scientific programs, with the members listed here, have 2 program co-leaders, one of whom is based on our Hershey campus, and the other is based at the University Park campus. And in fact, the number 2 person in the Cancer Institute, my deputy director, Dr. Jeff Peters, who I'm fortunate to work with, is a distinguished professor in the College of Agricultural Sciences at the University Park campus. If we were giving another talk, I'd tell you all about the great scientific resources we have in the Institute. But I just do want to point out that I have on the bottom here PSH, or Penn State Health Clinical Enterprise. And that's really the emerging health system that we're building, which is where we draw our patients from. And that's really, really important to what we do. Next slide, please. So one of the things that we're working to achieve is really to make it so that we get a special badge, if you will, of success. And that is something called National Cancer Institute designation. And this is obviously a map of the country, and each one of these dots that are listed here is a cancer center that has NCI designation. And this is a really, really important thing that we're aspiring towards, and we've been working on it, and we're actually quite close to submitting the application to the National Cancer Institute for this. As you can see on the right, this NCI designation is really important because it moves us into a club, if you will, of other centers that we work together with, and I'll say a bit more about it. At the present time, there's 71 NCI designated cancer centers across the country, and importantly, 11 of the Big 10 cancer centers or institutes have this NCI designation. One of the goals that we have, and the reason I was recruited here, was to really make it so that the Penn State Cancer Institute is the 12th of these 14 institutes that are NCI designated. Next slide, please. So why are we so interested in NCI designation? Well, I see in the chat that some of you are Western Michigan, but someone's from State College, and I'm sure a number of you are from Pennsylvania. And this map of the Commonwealth shows the counties that we have in Pennsylvania, and the black line that extends around the center of the map, or central Pennsylvania, is what we refer to as our catchment area. These 28 counties include 4 million people, or 31% of the population of the Commonwealth, that are really needing the sorts of bells and whistles that go along with having an NCI designated center. You can see to the west, Pittsburgh, and to the east, Philadelphia. There's one NCI designated center in Pittsburgh, University of Pittsburgh Medical Center, and there are 4 NCI designated centers in Philadelphia. And this heat map that you see has the oranger or redder the color is a higher percent of patients with cancer in that area that are treated at an NCI designated center. And so you can see that, close to 50% or more of patients in the Pittsburgh and Philadelphia area are treated in an NCI designated center. But in fact, in and around Hershey and Harrisburg and State College, you can see that a comparatively small percent of patients actually have the benefits of being treated at an NCI designated center. So why is that important? Well, it's really important because many of the cutting edge therapies that the National Cancer Institute has their hands on, they distribute to the various NCI designated centers around the country. And so for me and for us at the Penn State Cancer Institute, we are doing incredibly innovative treatments for our patients, no question about it, but we don't have the full access to the complete portfolio of agents and reagents and drugs that are distributed by the National Cancer Institute. So unfortunately, we rely on our friends around the region and around the country to get that for our patients, but that's something that we're working very, very hard at. And as I described, hope to achieve that really within the next 2 years. Next slide, please. So one of the things that we do is all about joining other centers. And I've already told you that 11 of the 14 Big Ten cancer centers or institutes are NCI designated. And a number of years ago, and this goes back to 2013, 2014, we actually formed the Big Ten Cancer Research Consortium. And we were one of the founding members, and I'd like to just play this 2-minute clip that will show you what it's about. When you're watching it, what I'd like you to pay attention to is, show pictures of the various Big Ten institutions. I'd also like you to just focus on the names a little bit. And so, okay, we could go ahead and hit play, please, and caption. Thank you. I can't hear anything.
Cancer is complicated.
It's absolutely exhilarating to see what you can accomplish today that was only a dream decades ago.
Big Ten Cancer Centers have united to transform the conduct of cancer research through collaborative, hypothesis-driven, highly translational oncology trials that leverage the scientific and clinical expertise of Big Ten universities. The Big Ten Cancer Research Consortium creates a unique team research culture to drive science rapidly from ideas to treatment-changing paradigms. Within this innovative environment, today's research leaders collaborate with and mentor the research leaders of tomorrow with the unified goal of improving the lives of all patients with cancer.
So thank you very much. So as I described, we were a founding member of the Big Ten Cancer Research Consortium. And that organization has really been set up to take advantage of the Big Ten cancer centers and take the basic science that we all are developing and get them into clinical trials. So for example, if I or one of my colleagues have a really great idea and that we'd like to put and test in patients to advance cancer care, we have a couple of mechanisms to do that. We can write the clinical trial and have it run, in this case, at the Penn State Cancer Institute. We can propose it to the National Cancer Institute and a number of organizations that are also involved with that. That process takes many, at least a couple, if not more years to advance those studies from concept to actually being begun and started. The other option we have is to really take these studies and open them up among a small group of like-minded institutions. And so what we elected to do back in 2014 was to form the Big Ten Cancer Research Consortium to really take it to be able to move these therapies, and in some cases, incredibly innovative therapies, to other centers around the Big Ten. So for example, studies that we have ongoing here include an incredibly novel approach combining radiation therapy with an immuno-oncology treatment. I'll perhaps say a bit more about that in the question and answer, for the treatment of recurrent bladder cancers, which has really revolutionized the way we think about treating bladder cancers and make it so that the more aggressive surgeries, which often result in someone having their bladder resected, may not be necessary. So that's but one example. We have other approaches where we're using combinations of new chemotherapy drugs for the treatment of, for example, non-small cell lung cancer, which in particular with work we're doing with Indiana University and work that's ongoing with the University of Michigan for treatment of leukemias. And for each of these studies, our different groups come together for this. Now, I started out the presentation by saying that we are Penn State's Cancer Institute. And in fact, what you saw, if you were paying attention at the previous video, the Penn State Hershey Cancer Institute. And some 6 years ago, that in fact was our name. But one of the visions that I had when I came here was to really make it so that we were in fact all inclusive. And so in fact, we were able to convince the Dean of the College of Medicine and the senior administration of Penn State University to allow us to make the name change so that our name is what's shown on this picture of our building. Now, for anyone that's sitting out in the parking lot out in front of the building, and I doubt you are, you would recognize that Hershey is still on the building, although we're in the process of changing the lettering to represent the current name that's here. So that's the first thing that we have, and is to make really the Penn State Cancer Institute inclusive of all of Penn State. So the scientific ideas we have, things that are, for example, in engineering, in the College of Agriculture, sciences, to really take those discoveries and get them into clinical trials that we can really get out to the Big Ten Cancer Research Consortium and beyond. So if we can go to the next slide, please. So the major initiatives that we've had are really the Big Ten Cancer Research Consortium, which I've just talked a little bit about, but I do want to back up a bit and tell you again that we are Penn State. So my mantra was that we're all inclusive, and every single faculty member and investigator at Penn State University that's even remotely working on cancer, I want to know about them, and my senior leadership team wants to know about them, and we want to engage them and work together to advance our treatments. The second thing that we have, which is absolutely extraordinary, as I'm sure all of you know, is THON. And so Thon, which was really established, is as an incredible, an absolutely incredible event, raises on the order in recent years of $10 to $13 million a year for pediatric cancer research. Most, if not all of that cancer research goes on in the College of Medicine at Penn State University in Hershey here. And so one of the things that we've done is that we've really more fully integrated the pediatric cancer research programs into the Cancer Institute. And in fact, one of my associate directors is the Associate Director of Pediatric Oncology for the Cancer Institute. So we make sure that we're really harmonized in what we do for with pediatric cancers and adult cancers. As some people have overhear me saying, I'm absolutely for what Thon is, and that's for the kids. Absolutely, it is. What I would say is that I would say for the kids in my book also means being able to cure their parents and grandparents of cancer, so that the kids are able to live with their family members and their family members live longer. And the fundamental mechanisms that underlie pediatric cancers and adult cancers are very, very similar. For example, one of the studies that my group was involved with in our focus on brain tumors is really that when you look at a certain type of brain tumor called glioblastomas, and you look at them in children versus adults, what we find is that they're the same individual molecular mechanisms that underlie those cancers. But in the children, there are only one or two driver abnormalities, if you will, things that drive that cancer. In the adults, there tend to be many, many more drivers. So the point is, the longer we live, the more likely we are to develop these mutations that result in cancers, but the cancers can look very, very similar. The other major step that we've really taken is to better integrate the other cancer treatment areas that we have. And so I have but one example listed here, the neurosciences, because, for example, at the Penn State Medical Center and the Cancer Institute, we see more primary brain tumors than really anyone else in this part of the country as a single institution. I've already talked a little bit about the Big Ten Cancer Research Consortium. We're very, very excited about this, and we look to advance things moving forward. In terms of other things that are more timely, we are one of the early participants of something called the CCC19, or the CCC19, the COVID-19 and Cancer Consortium. And this group was organized, not surprisingly, about 7 or 8 months ago, and has been really looking back at patients, not only in this country, but around the world, looking at patients with cancer and what happens if they also happen to get COVID infections. So, are the questions we're asking are, do they appear to be more susceptible to COVID infections? What happens to their outcome what happened to their outcome with COVID? What we know is that if we look at cancer by cancer, if somebody has a cancer and they happen to be infected with COVID-19, they have a 3 times greater mortality rate than just having that cancer alone. So cancer patients are really, really at high risk for having very, very bad outcome with COVID. And that extends much beyond what we would have expected to see. The other thing that we're working on with COVID is something called the NCI, National Cancer Institute COVID-19 Prospective Study. So the CCC19 is looking back, having us all look through our records and seeing, what has happened to our patients. The NCI study is really prospectively where we actually enroll our patients that have COVID and cancer, and we look to see how they do moving forward. And so we're really quite excited about being able to participate in that as well. If we go to the next slide, please. So that was really all I intended to formally cover here. I do, have my email address there, and I have a number of different email addresses. This is the shortest one that gets to me. And if anybody is interested in sending me an email with questions after the presentation, I'd be more than happy to respond to you. The other thing I would say is that the picture on the upper left here is the picture from the lobby of our Cancer Institute building. And the Cancer Institute building, it's a little bit, so this photograph was taken looking west. So the entrances to the building would be behind this photograph. And this is looking west. And you can see that there's these 4 research impact discovery innovation flags hanging. And then you can look up and see an atrium above there. And if you look on the right side, where you see the white drape that's hanging, the second one from the left, or the second one from the right on your photograph, you can start to see balconies. And so the way the Cancer Institute building is designed is actually pretty innovative in the context that there's the first 2 floors and the ground floor below ground are related to patient care. And so the patients come in, and much like this photographer who took this picture, they look into the lobby and they can look up. And there are patient waiting areas that are underneath this area that you can barely see the top of. The 3rd and 4th floors of this building that go up to the skylight, these are where the research laboratories are. So the researchers are supposed to be able to when we were doing less social distancing, actually look over the ledge and look down and see the patients in the waiting area and say, aha, that's why I'm coming to work every day. And the patients could look up and say, that's why I'm coming here, is for the discoveries that those individuals are making. So, I think it's a great story. I know it's true because I've been told it by a number of individuals. But I think what I'd like to do is go ahead and stop here and spend the rest of the time entertaining any questions that you might have.
So Dr. Hohl, a number of questions are coming in. First, thank you for your presentation. My internet is a little unstable, so I'm going to stay off screen so that I can get the questions that are coming in. The first question that's on my mind is the NCI designation. Is there anything about being treated at an NCI designated hospital or center? Is there anything that impacts my treatment, whether I'm treated there or somewhere else?
So what I can tell you for the Penn State Cancer Institute is that we do absolutely state-of-the-art care. So, you would get the absolute highest quality care coming here as you would at an NCI designated center. The one thing that you would not be able to get were you to come here would be certain types of experimental therapies that might offer a better option for you. Having said that, because we're in the network and we're what we refer to as an emerging center, and we've already met with the NCI, they know who we are and they know we're coming, we built up a really good network, so we know what these agents are, and we make a determination as to whether it's most appropriate to actually send you somewhere else where they have those treatments, or those treatments are not really what you need right now, and we would provide the first-rate care that you get. So from a practical standpoint, once the decision for treatment is made, there's not, at least for Penn State, there's not a difference. The Penn State, the NCI designation, if you want to think about it more broadly, it's kind of like the good housekeeping seal. If they give me a little pin I can put on my lapel here. They teach me the secret handshake when I go to the Fed, NCI. So there's, and I'm just kidding with those, but we really, the kind of care that we provide, not only in the Cancer Institute building here in Hershey, but really in our network. So in the map of Pennsylvania, you may have seen, I had Berks County listed there, and as Part of Penn State Health is St. Joe's Medical Center at Berks, and we have our faculty. Our oncologists are working there. We also have the Cancer Care Partnership at Mount Nittany Medical Center and State College was designed to have our faculty be the oncologists that work there.
So I think what might have been eye-opening to some of the folks on the presentation today is the amount of research that's being done at University Park. I think we think Penn State medicine, or at least we've been conditioned to think over the years, Penn State medicine is almost synonymous with Hershey. But now in recent years, that all has changed. Can you talk a little bit more about the type of research happening at University Park and what the relationship is between Hershey and Mount Nittany Medical Center?
Sure. So first of all, you're absolutely correct. And one of the things that, it took me barely a half a day to be here some 6 years ago when I was looking at this opportunity to recognize that there were enormous opportunities at the University Park campus and in State College that we really weren't taking full advantage of. We were taking advantage of some of it, but not to the fullest extent we could. So I actually, I haven't been up there as often lately, but one of the early things I did was I actually have an office up in the Ford building, if any of you know where that is, on the 5th floor at University Park. And so we've been, and that was really for me to really talk to the deans who pointed me to department heads, who pointed me to their faculty, that were doing interesting cancer research. And so, for example, some of the work that comes out of material sciences is work that's using nanotechnology or nanoparticles to really put one of our chemotherapy agents, a drug called gemcitabine, which is very effective for the treatment of pancreatic cancer, into nanoparticles that have a high, very, very high affinity for the pancreatic cancer cells. And so the particles are taken up by the cancer cells, and then the chemotherapy drug is released. And it's a way of getting higher concentrations of the chemotherapy drug into the cancer and keeping the concentrations that are in the rest of you lower so you don't have as many side effects. There's another investigator in material science, and she's doing amazing work with something which the way I think about it, it's the origamis of material science. And so there are certain cysts that form in different parts of the body, and these cysts can be precancerous. And these cysts are not always completely round. Sometimes they have a very unusual shape. And so what we can do is using imaging, CT scans and other imaging techniques, we can know what the three-dimensional look of that cyst is. And then she and her group can design basically a metal antenna, if you will, that fits inside that cyst. And it expands, so each one of the points goes to part of the wall of the cyst, no matter what the shape is. And all of these have to be individually made. But in order to get them into the cyst, what you've got to do is take this metal contraption and fold it up into a really tiny little sphere and then put it into the cyst. And what happens is that they put it into the cyst, and basically, because the metal has memory, so it will remember what its shape was, it expands to the exact contour that it should be. And we use that as an antenna to get radio waves to actually increase the energy that goes to that and ablate that cyst. The other thing that we're doing, and we have a new investigator, Professor Deb Kelly, who we were really fortunate to recruit into biomedical engineering. And she's actually one of the leaders of one of these 3 scientific programs I described, the next generation therapies. She's actually able to look at the molecular level as to what a molecule called BCR or called a BRCA, which is a breast cancer susceptibility gene. She's able to look at that molecule with such resolution that we can actually design molecules using the chemistry department up at University Park to really inhibit the active site of that BRCA molecule. and therefore make it so that we can change how women with those cancers actually behave.
Right.
So that's just an example. In the answer to your second part of the question, the relationship with Mount Nittany is, so we do have the Mount Nittany Medical Center. It's a private institution, certainly, but it is really the focus of what we refer to as our regional medical college or regional college of medicine. So we have a number of our specialties, in addition to oncology, that are practicing up there and really work to provide the care that for those of you that live in State College, that the care that you'd receive if you went there. What we've been doing increasingly, and this is really work that has been spearheaded by our new senior vice president for research, Dr. Laura Weiss, where we've actually had meetings, we've had gatherings, not in the last couple months, but of the Cancer Institute investigators at the University Park campus with the physicians at the Mount Nittany Medical Center to really look for opportunities to advance our basic work into clinical studies that can be offered to patients that are being treated there.
So a couple questions coming in. I'm going to lump these into kind of the institutes or the hospitals kind of area of coverage or their service area. So first question, when you showed the map of Pennsylvania, it appeared that the northern tier counties weren't served by any of the cancer institutes. Are we to assume that maybe it's Cornell or Upstate Medical in New York that might cover those areas in northern Pennsylvania?
Yeah, so the very top tier of counties that I showed there, so they are, in all likelihood, they would be Cornell. It doesn't mean that we don't have an interest in going there by any means, but when you get some of the counties, so for example, especially up, so Sullivan, some of these counties are very, very rural, and in fact, and that's the striking thing we have. For many of you, probably most of you that have been in State College, you don't have to travel too far out of State College, and you're really in the country. And in fact, I'm reminded a week or two ago, I took a photo of a black bear on the State College campus, and some of the counties, to give you an idea, where the areas in the counties where Bucks County or for Philadelphia, they have population densities in the many hundreds per square mile. There are some counties that we serve that are in our catchment area that have less than 20 people per square mile. So that is really, really rural. If we had unlimited resources, you bet we'd be up to those counties serving that population. The diagram I showed with the 28 counties, that's really configured for purposes of what the National Cancer Institute is expecting of us in terms of what area we need to fill and what's our void.
Right. The other question as it relates to service area, I'd probably put this in the category of kind of brand recognition, right? I mean, certainly we see this with children who are battling pediatric cancer wanting to be treated at Hershey because of the brand that has been built over cancer treatment and pediatric cancer treatment at Hershey. How is it determined whether a cancer patient will be treated at Penn State's Cancer Institute or at their local hospital, or how are those determinations made?
And so fundamentally, it's up to the patient at the end of the day. But what we can do is, for those of us that see a lot of patients, myself included, we have a pretty good sense as to what sort of therapies are relatively easy to deliver and which ones are technically harder to deliver and require more resources. I want to be very careful about, so my colleagues, the oncologists that are practicing in these more community-based areas, most oncologists, they have the expertise and training to treat almost anything. The challenge is less their ability to treat it, but the sort of infrastructure that they're practicing in terms of, what's the hospital like? Is there a blood bank? What are the sorts of bells and whistles that they would need in case patients run into trouble? And so we're very careful about making sure that, patients are in an environment where, if things go well, things will go great. But if they start to go wrong, we've got all the ancillary support services that can help pull people through it. Kind of one of the most innovative things that we've been working on, and this has been in the news a lot lately, is something called CAR T therapy. And CAR T therapy is a process whereby we remove your blood cells, we collect them, we ship them off to a company. They take a month to genetically engineer those blood cells, these immune blood cells. They ship them back, and then after we give some treatments to alter your immune system, we transfuse these genetically engineered blood cells back into your bloodstream, and they actually take up residence in your bone marrow, and they will attack your cancers. And this has been FDA approved now for the use of treatment of lymphomas, adult and pediatric leukemias. We have projects going on, and most recently, we're also using it for patients developing with certain solid tumors as well. So that sort of therapy, which is really manipulating the immune system in such a way that people are really potentially at great risk for things to go wrong, that's where we would want to do it here at Hershey. On the other hand, we're more than happy to be, as I'd like to say, we want to be your community oncologist best partner in terms of, kind of working so that patients can receive therapy close to home, but they can receive it appropriately and safely.
So a couple questions that I want to get to, shifting gears a little bit here. What efforts are being done to address the long-term side effects from cancer treatment and educating doctors on how to address these issues?
Yeah. So for, I'm absolutely certain, since I know that, about 1 out of 4 people will have cancer, that a lot of people on the call, on the meeting will have had cancer themselves, and most certainly will know people. And long-term side effects of cancer therapy, and we see this in pediatric patients that have survived their cancer, is very, very difficult. There can be nerve damage, so-called neuropathy, where people have trouble buttoning their shirts or their blouses because they can't feel things very easily. It can lead to heart damage. It can lead to lung problems, overall deconditioning. And what we are doing is, number one, we're better understanding the mechanisms for how those happen in developing new therapies that have all of the benefit without the side effects. The second thing we do is that we do have certain drugs that are called protectants. So we give it along with the chemotherapy drug where we know it damages something, but because we know why that damage occurs, whether it's in the heart, for example, we can give a medication that will prevent that chemotherapy drug from damaging the heart while it's being given. So we have a number of strategies like that. I think the other thing that we are looking at very carefully is, when I started in oncology some 35 years ago, we were really, as an oncologist, we always thought, we absolutely have to give as much as we can. So, the more is always better was our slogan that we lived by. And that's because we weren't doing a very good job of curing a lot of cancers. What we're finding out is as we get better at curing cancers, we're finding out that there are some groups of patients, subtypes of patients with that cancer, that we don't have to give them as much therapy as we used to have them be cured. And so we're better understanding who needs the really intensive therapy and who needs perhaps less intensive therapy. So those are some general, answers to your question.
Yeah, I think what you're talking about is kind of the balance between curative care and palliative care. And can you maybe just expand a little bit on that? As we've gotten better at curing diseases, how have you brought kind of palliative care along with that?
Yeah, so palliative care has been really a great addition to our armamentarium. And it used to also be said that you either were treated by an oncologist, presumably for cure, although as I already told you, we weren't curing as many people as we really thought we were. Or we were sending people to palliative care, i.e. hospice. And I want to really emphasize, palliative care is not, and hospice are not synonymous one with the other. And in fact, a lot of what we historically have done as oncologists for cancers that we know we don't really cure has been palliative care. We've been providing treatments that have patients live much longer, but we really can't cure their disease. So for example, in my practice, I see, in addition to the major focus areas I described, I see patients with other cancers as well, and women with metastatic breast cancer, where the breast cancer has come back. Many of these women can live for many, many years by having us use agents judiciously and intermittently during the course of their disease. And so in a sense, that's palliative care as well. Now, when we reach the point where we have absolutely nothing else to give, or when the treatments we're giving, the side effects of those treatments so outweigh the benefit that the patient is getting with regard to control of their cancers, then we talk about really end of life sort of, we don't start talking about, we talk about that early on. So I'm a huge fan when someone's first diagnosed with cancer, the very first visit I see them, first or second visit, I have the conversation, we're going to talk about this now so we can talk about it and make sure I'm optimistic things are going to go well for you. I can't guarantee that, so, assume the worst, make sure, all your affairs are in order and everybody what you want done. And then we're going to focus on making you live as long as you can. So when we have those critical decisions we have to make, you're not worrying about, oh my God, I didn't put my will together yet or this. So I think that increasingly what we're doing is we're pulling the palliative care approach, which is all about symptom control and quality of life. We're really putting that smack in the middle of our treatments for cancers itself, and really making it so that people not only live longer but live with a much better quality of life.
So we have time for just a couple more questions. Shout out to Kirsten Ingraham, who submitted these last couple questions. Penn State class of 2001, working at the Duke Cancer Institute, Office of Health Equity. First question is, is there a centralized website that you could share where you share peer-reviewed works from the Penn State Cancer Institute researchers? They'd love to learn more about that.
Yeah, so thank you, Kirsten, for that question. So we do have a website, and the website itself is easy to find. We're in the process of upgrading it so that it becomes much more user-friendly. As you might imagine, a lot of it is focused at patients. So people that are looking and seeking what sort of clinical services we might provide, but we are expanding a section in there where we have the researcher that would be of greater interest for researchers. So Kirsten, if you go ahead and email me, I'd be happy to kind of send you more direct information related to that.
A follow-up to that question, and I think this might have to be done over email as well, is there a way that Penn Staters who work in the cancer care field can network with each other? How can alumni connect with each other?
So send me an email. So we would be, on the, so we are very interested in setting that up. We have community advisory committees that we work with, especially for certain regions of the 28 counties that we serve. and I have something called an external advisory board, an internal advisory board. But I would be keenly interested in getting a handle on how many of the Penn State alums are really working in cancer, either as a cancer researcher, a healthcare provider, or have an interest in it. I think that again, if you send me an email, I have one of the individuals from my team here, Jenny Miska, who actually works with me in the development office. So don't run away from that. But we've been trying to organize, who our community is, and I would say as Penn State alums, you're part of who we serve as well. So.
Absolutely. Well, Dr. Hohl, there's a lot more questions that have come in that we don't have time to get to. We will be sending a follow-up email out to all of the participants. We will include your email address in that email so folks can reach out directly to you. But we want to thank you for all the great work that you're doing at the Penn State Cancer Institute and for sharing that work with us today. Thank you very much.
Yeah, thank you, Paul, and thank you everybody for attending. I have to tell you, if this was in person, you'd see me walking around. I feel a little bit constrained sitting in a chair here, going ahead and giving this. But I will say that this institution and the Institute, this is an incredibly exciting place to work at. And when I say that, it's not just the Institute building in Hershey, but it's Penn State University. And so as a non-Penn State graduate, I'm honored that I've been able to kind of get in front of all of you today. So thank you so much.
And we want to thank everyone else for participating. This is just one in a series of virtual events that we are offering through the Penn State Alumni Association. You can find out more information at alumni.psu.edu/events. Thank you for participating and for all you do for the university, for the glory, and for the future. We are
Penn State.
Thank you.
Thank you. Bye-bye.